Hey everybody, it is Nicole here. How are y'all today? I just wanted to let you know that we have Abigail here. She'll give us a brief description or biography about herself in just a sec. But if you're here with us live, I will be putting this in Optima for you. And if you're watching this recording, please make sure that you enter it in Optima so that you can get credit for it. So without further ado, I'll go ahead and hand it over to Abigail. Thank you so much for being with us today.
Of course, I'm super excited. CASA is definitely an organization that, I've worked with in the past. So I'll kind of just go into a little bit about myself. Again, my name is Abigail. I am currently a qualified mental health professional with Coastal Plains Community Center. Okay, and so Coastal Plains services 9 different counties surrounding Oasis within Region 11. Okay, and so we're also commonly known as the MHMR. It's usually what most people, once we say that, they're like, oh yeah, that place. So Coastal Plains, right, provides services for mental health challenges, behavioral health challenges. We also have a psychiatrist, or we have several psychiatrists also that just kind of rotate between the different centers we have. Services we have a wide range of services. There's case management to provide like the skills training, right? Or service coordination, routine case management. We also have our counselors who provide CBT services. We're contracting with a psychologist who's going to now be able to service the need of psychologicals, because there really is an extensive need in our area and not very many providers available. We do crisis intervention as well. And so our area does tend to see a lot of crisis, especially within our Alice, San Diego area. We are building a substance use center, and it'll also serve for crisis drop-ins. And that'll be in our Alice location. So it's going to be a brand new center. We're hoping that by the end of the year, that will be up and running. It will, I believe, service all of the different 9 counties. They may just be transported. We oftentimes find that whether it's a youth or it's an adult, we do struggle at times to find beds at a psychiatric or behavioral hospital. Just because of capacity, right? And so they'll kind of sit with us and wait for quite a while to get admitted. We do utilize our local ERs as much as possible, and we've just built such a great partnership with them and our local either law enforcement, sheriff's department to help us with that as well. So that's just a little bit about, Coastal Plains, so what we do. Overall, the program that really works currently with DFPS is the program that it's a grant that's been funded by HHSC, and that is the program I oversee. And so my title is very long, right? I am the Children's Mental Health System Navigator. It is a pilot program. The grant was awarded for 2 years. We're about a year and a half in. It's kind of been like starting up from the very beginning. This is my baby. So it's been, trying to build it up, trying to reach out to different partners, trying to really work and weave my way in through DFPS and the variety of departments that they have, right, and personnel. We are kind of starting to get to a point where I'm making a little bit more progress. For a good while there, we were seeing some barriers, okay? Kind of backtracking to myself, I have over 10 years experience working mental health. I would say roughly about 5 years experience working with foster care. I was a previous foster care parent, an adoptive parent. And then I worked as a case manager, of course, and I was also a regional director in Region 8 and Region 11. So I've seen it, right? I can say I have lived experience. I've seen it from the different perspectives. I've seen it as a foster parent. I've seen the need as, director when it comes to not having enough mental health information. I've seen it from, the foster parent, adoptive parent, where there may not be enough resources in place, or there are. It's just, do we know about them, right? And it can get time consuming. It can get very time consuming for some individuals while they're trying to address a need, or they're trying to help advocate for a youth or the family to actually go out there and find those resources to help them. And so HHSC, about maybe 2 years ago, saw the increasing need for youth that were going into CWOP, children without placement. And so they said, okay, we need to figure out a way to service these needs, right? There's these needs that are going unaddressed. These youth are going into CWOP for many different reasons. And so we need to do something and put something in place where us as HHSC are supporting DFPS, because they're two different entities, right? And so they created this position. They went back to the state, did what they need to do, got this grant pilot program, and they said, okay, we're going to pilot this in 3 different regions. So you have Region 11, Region 8, and Region 2. And so I was lucky enough to get all of Region 11, under me. And so I coordinate with 4 other LMHAs. Okay, so there's Gulf Bend, there's Coastal Plains, Nueces, MHID, Tropical Texas in the Valley, and Border Region. Okay, and so I work specifically with the children's mental health directors for each agency, or their assigned program managers or assistants, right? And so I work in collaboration with them whenever we have referrals, right? The process is to have referrals coming in from DFPS to help addressing those mental health or behavioral health needs. So I'm not going to go through every single item that's listed on the PowerPoint. I'm going to leave it there while I kind of just keep talking for you. The program is really working to network. It's working to enhance those partnerships, provide a more in-depth collaboration between different organizations. I was extremely excited when I got to meet, Nicole at that back to school bash, because it was like, oh my gosh, you're that link that I need as well. And so, it tells me we're moving in the right direction. As I mentioned, there has been some barriers with, pretty much everything. DFPS also saw the increasing need really for the youth going into the CWOP program. And so they created what they call clinical coordinators. Okay. And so those clinical coordinators are my go-to. We will kind of work in partnership. And so the clinical coordinators are the ones who, once a youth goes into CWOP, they're responsible for finding the placement. They're responsible for ensuring that all of their needs are met, not just mental health and behavioral. You're talking educational, medical, maybe psychological. They are there to locate providers. So with that, I've been, again, very blessed in the sense that my clinical coordinators from Region 11 got it together. They've been working with DFPS for some time now. And so they have been able to build really great relationships with external providers outside of an LMHA. And so with those partnerships, they're able to go to them. They're able to refer to them, right? And they're able to say, hey, this kid needs to be seen because they may need medications. Can we get a psych evaluation? Boom, done. They go to a counselor and they say, hey, this, youth has experienced trauma. They're presenting with some behaviors. And, the counselor is like, okay, we'll take them in. Boom, done. The issue we find all too often is that medication and counseling, they're not a fix-all. And, there's no specific type of medication that's just going to say, okay, take this and it's gonna take away all the symptoms and all the problems. It doesn't work like that. Medication probably accounts for maybe 30% of reducing symptoms. The remainder of that is applying coping skills, is learning how to reduce the symptoms by channeling that into something positive, right? Also discussing through trauma-informed care, aside from CBT, to address that trauma issue. So one of the things I go back to DFPS to do is to teach them, educate them. This is what mental health is. And this is what your local mental health authority can do to help you and assist you, right? Because no matter where you go throughout the state of Texas, there is a crisis hotline, a local crisis hotline that will link you to a local mental health authority, right? Because we're state and federally funded. And so, no matter where they go, if it is specifically a non-insured individual and they present at a hospital, the hospital themselves are picking up the phone, they'll call the crisis hotline, and someone from an MCOT team, which is the mobile crisis outreach team from whatever local mental health center is, around them, is going to go and do the assessment, the crisis assessment for that youth, adult, regardless. And so then that center is making the decision whether that individual is going to be hospitalized or not. Okay. And there's a little bit more complications to that. I think that would be, just so we don't get off topic. So this grant program, right, works to help ensure that we're reducing those crises that we continuously see. It's to help reduce the amount of time that a youth is spending in CWAP, okay? It is created to help continue to promote the enhancement of mental stability. So the sooner that we're able to identify the signs and symptoms of mental challenges, then the sooner we can provide the intervention, right? And so then the sooner recovery can happen. Even if it's a youth that they're at the point where it's a crisis and crisis intervention has to be provided. I'm sorry, somebody's knocking at the door. Give me a minute. So as soon as that can happen, recovery can happen in any stage, right? Whether it's at the very beginning and we're able to see the signs and symptoms, or it's during a crisis. Regardless, recovery is possible. And so aside from the youth that are already going into the CWAP program or who are currently in the CWAP program, this program, the Children's Mental Health System Navigator program, long title, right, is also working with those youth who are at risk of losing placement. Okay. And so I say, think about little Johnny, right? It's always little Johnny. So think about little Johnny who was removed from care, and it's already been 6 months, and little Johnny has moved 3 different times from placement to placement. And it's always behavioral issues, right? We hear it, behavior. And, we're kind of like, okay, well, what is foster parents doing? What is the agency doing to help de-escalate these situations? What's in place? What's going on? And then you finally get to a point where he's already built up this rap sheet, right? Every time CPU is trying to place him, there's this rap sheet, and you have agency after agency saying, nope, we don't have a home. Nope, we don't have a home. Because he's now gone from that basic, moderate, therapeutic level, and he's intense. And it's like, okay, where are we going to place him? So then we automatically start thinking RTC. He ends up in CWAP, we start thinking RTC, but it's like, what true intervention was provided to little Johnny? How many times did we try to understand the behavior challenges, right? Did we identify that there was a mental health challenge happening? What's his past trauma like? Little Johnny doesn't know how to sit there and explain to you, this is my mental health. I act out because it's my anxiety. Little Johnny doesn't know how to express those things. As adults, we don't always know how to express those things. And so this is what this specific program does, right? This program allows me to develop a wide range of training information to then go out into the communities, to go out to different organizations and educate and teach on the different mental health challenges. And I say challenges because, we're all presented with something different, and it's not so much of a disorder. A disorder until there's a diagnosis, right? So teaching to learn what those signs and symptoms are, so we can start to intervene early, provide that early intervention, which when I was a foster care director, when I was a case manager, when I was a foster parent, we'll go all the way back to that. When I was a foster parent, I spent many, many nights crying, many moments crying, because I knew that there maybe was resources out there, but I hit roadblock after roadblock after roadblock. And it was very difficult. Sometimes the response I got from my CPS worker, who was managing the case for the kids, would say, I talked to my supervisor and my supervisor said, just send it back. And it was like, these are my kids. This is my heart. There's no way. Help me, help them. Teach me. When I initially started going back to school, my degree was for healthcare administration because I was an office manager with a home health agency. Does a little bit of case management, you know, you're providing home care attendant services, you're working with the elderly and disabled population. But I was so set on learning different ways to help my children that I said, I have to do something. And so I changed midway through my program. I said, no, I got to figure this out. So I changed into social work. So I understand that this need is here. And I wish, you know, that mental health has grown just drastically, right? There's so many different programs. You have mental health first aid. That is an amazing resource. It does scratch a little bit of the surface. It teaches you how to apply what they call the ALGE action plan into a non-crisis and crisis situation. And so when you complete that training course, you receive a certificate that you are now a mental health first aider. And so it's to help you recognize those signs and symptoms early on. It's to help you provide that crisis intervention. And then it also helps to teach you how to link individuals to the appropriate resources, right? But like I said, it's one of those that scratches the surface. You know, it doesn't really go into too much detail about crisis intervention, behavioral de-escalation, which are the topics that our foster homes need to know, right? That is what that would be beneficial for them. And so, like I said, this program allows me the availability to really develop whatever we don't have, to come back out and teach and talk and discuss, you know? So the screen that's up here just shows you, this was from back in 2021. I haven't received an updated statistic, really. This shows you how many individuals were in CWOP and the length of time, where they came from. You know, so you had 20% to 24% that came out of a psychiatric hospital and went into the CWOP program. And again, it's one of those where homes become less willing to take in a child who is getting, discharged from a behavioral hospital because of the problems that they're presenting with, the challenges, right? We see them in mental health as a challenge and other people see them as a problem. And so that's part of the stigma. And that's, again, something else that I'm working to really try to change. So then you look at the ages, right? The age groups, and you also can see here the length of stay. And so you can see the dark blue that the older the child, the longer the stay, right? Difficult situations, right? Sometimes they're able to find a placement. There's a home that's just available and willing to put in their part. Unfortunately, there are youth who go into placement and then they go back into CWOP, and it's kind of a flop until they age out. Some will just stay in CWOP the remainder of the period of time until they age out because they are not able to find placement. Very sad situation. So what does my role continue to do? We coordinate, I facilitate, I provide access to the intake services to connect, right? Rapidly connect youth to the mental health center. It's great and it's fine that they have counseling services already in place. They can continue with their counselor because the service that they can also receive through the local mental health authority, right? The MHMR is different. The skills training, the case management is different than what DFPS caseworkers do, than what GASA does, than what the counselor does. that skills trainer, that case manager goes into the community, whether it's at, let's say, the hotel that they're currently placed at, the school that they're attending. They can pick up the child, take them to the restaurant, they can take them to the park, and they work on the skill, right? They talk about a different skill. They talk about, what's currently going on. They will also touch base on, what they're working on with their counselor. The case manager will coordinate with the counselor to see where are we, so they can work in collaboration and they continue to help the youth make progress. So like I said, I do meet with the different children's mental health directors on a regular basis. We meet at least monthly. I give them updates to the program. We talk about any barriers that have been presented. And this is just to allow us to continue to say, we want to move forward. We want to be able to provide more rapid services. We want it to be quick and efficient because that is a barrier that we've been presented with, right? DFPS tends to shy away from bringing clients to us because the intake process is lengthy. Getting an appointment to see our psychiatrist is lengthy. And so I encourage the clinical coordinators to continue to use the providers you have. There's no problem in that. I'm saying utilize the additional services that are provided by the LMHA because they're beneficial for them. The state HHSC is saying we have all these services in place, and yet the children who are in foster care are not utilizing them. Why? So that's what we're, working towards, trying, like I said, to provide the education, make the community aware, help to make our community partners, right, like CASA, aware of the program. And so that, referrals are just filtering through. Like I said, keep in mind, we're state and grant funded. We service already a lot of consumers. We provide services to insured and non-insured. There's times where, depending on the eligibility, a client can possibly have a cost of zero and they still receive all the same services. That's just the beauty of it, right? That's the benefit of it. We also do have integrated care. So clients can receive medical-based services, which are usually for chronic conditions, just maintenance conditions. Variety of, like I said, services. I do coordinate also the RTC program. So if I have a youth who's already receiving services with us and the referral comes in from CPS because of those presenting behaviors that they are possibly at risk of no placement, we start doing the application for the RTC, right? And so we'll coordinate, I'll try to get the psychological done, we'll complete the application. The difference, though, is that when DFPS is submitting an RTC application, it's going direct. When it's coming through the LMHA, because they're already receiving services, they do require that individual, whether it's the foster parent, it's the guardian, it's the biological parent, to play a role, right? They have to be willing to participate. And the idea is that youth is going to come back out into that home for placement once they're discharged. So that's just part of RTC. It's another, piece of the puzzle that I do service, along with, coordinating with the different services in the different centers. This is a little bit of the schedule of events that I initially created when the program rolled out. And like I said, we've hit a lot of different barriers. And so I'm still working with DFPS. What I've seen is that there is a great, great need to educate, to go back and to teach on the different diagnoses that are out there, to teach on what signs and symptoms there are, right? I am a mental health first aid instructor as well, and I teach, classes just all over South Texas, I should say, San Antonio and kind of down. And I will tell you that every community is slightly different in how you service them and how they respond. But the one thing they have in common is that there is a huge lack of knowledge when it comes to mental health. And that stigma is still very high. And you're talking about educating professionals, law enforcement, teachers, medical personnel, partnering organizations, social service organizations. DFPS, you know, it's just, we talk about it, we know common diagnosis, sometimes we build a misconception, and so we don't really identify these. Like I said, a lot of the time when a youth is presenting with a challenge, we see it just as a behavioral issue. They're acting out because they want to go home and be with their parent. They're acting out because XYZ. Well, again, teaching on these, the difference on signs and symptoms of mental health is to help foster parents, foster care agencies, DFPS workers see that it's not just a behavior, there's also that mental health challenge in place. And it's not just a medication that is going to fix this or to help them. It's not about having these kids highly medicated to zombie them out to where they are not displaying any more behaviors. Like I said in the very beginning, how can a youth tell us what they're experiencing? So this next slide is just showing you how, again, things kind of filter through. You have the youth who enters or the youth at risk of no placement. CPS worker coordinates along with the clinical coordinator. They do the medical care, the educational needs, and then they work in collaboration with me to ensure that their mental health mental health and behavioral health needs are being met. And so aside from that, at times we do have youth that present with continuing ongoing issues. And it's like, hey, they've already seen this counselor, they're discharging them, they don't know what else to do with them. The psychiatrist is kind of like, can't provide services anymore. Where else do we go? That's, my role steps in to say, let's find you a new resource. That's my contact information. I know I'm quite a talker. There's a lot of information. Like I said, I'm very excited. When I met Nicole, it was just kind of like, oh my gosh, type of deal. What I'd like is that, if you all, because you're there, you advocate for these youth, you work with, different families with different youth. I'm trying to gather information to see what other mental health, behavioral health, crisis intervention, behavior intervention trainings are needed. What is it that the community needs? What else is out there that you may not know? Is it certain diagnoses? Is it just knowing what resources are? Like I mentioned before, I am open to developing whatever trainings are going to be beneficial.
I am, for one, really excited to hear about this. I didn't know what was going on there. And I love that your enthusiasm regarding training. And I'm sure that I can speak for the advocates as well. We'd love to have you back with more detailed, maybe trainings regarding different diagnoses and signs and symptoms we can look out for as advocates.
Yeah, for sure. So I know I am working with the other two navigators in trying to develop kind of like a schedule, whether we do it virtually and we rotate between the three of us to provide the trainings with a variety of topics. And so one thing, again, I'd like some feedback on the different types of topics, just to really also see what is the knowledge base, right? How much do you know about mental health? How much do we know about de-escalating behaviors? What resources do we know are in place? And so there's a survey I'm working on. And what I'd like to do is, I can, if you don't mind, I'd like to send it to you, Nicole, and then you can disperse it, and it's just really going on there and filling it out and just sharing with me. What just kind of clicking on the different responses. That'll give me an idea as well. I'd like to produce at least a monthly schedule of different trainings. And that way, individuals are just able to kind of jump into whatever training or doing one specialized. If you have a monthly meeting that you'd like for me to jump in, do a 15-30 minute training, not a big issue.
Are you able to provide CEUs for your training?
I can double check on that. I can double check for you, and that way we have a solid answer.
Okay. Any questions from our audience here? And you can also ask questions in the chat.
I'd like to make a comment, Nicole.
Yes, ma'am.
Mariam. Okay. Okay. Can you hear me?
Yes.
I listened to Abigail, and I'm not sure that I picked up. Thank you for your presentation, Abigail. I found it very interesting, and I listened to what you had to say. And so far, my luck of the draw has been little kids. When I say my luck of the draw as a volunteer, has been little kids. And I had a kid on a case, and I was totally puzzled because he presented normal. He had normal social skills, but he was 10 years old and was doing so badly in school. And I mean, and I don't know how it got undetected because I think because we went through COVID, but there was a disconnect between his presentation and his underlying situation, and it was mind-boggling to me. And I pushed and pushed and pushed, and we got him tested. And needless to say, he flunked out everything, right? And in other words, like you test positive for COVID, he tests positive for every single learning disability that you could think of. And but this kid presented normally, spoke normally. And I think that probably in kids, mental health problems might be something like that. They might look normal, sound normal, but there's something going on that it just doesn't add up. There's got to be something wrong. And and girls are different from boys because girls internalize and boys externalize, they say. They act out, girls, get depressed and keep quiet. I just wondered if there was anything that you had that looked at kids. I mean, CASA is all about kids, right? They age
Right.
out at 18. So, but I'm talking about little kids
Right.
who
So,
can't articulate.
it is very unfortunate that the age we start to see mental health challenges has become younger and younger. The local mental health authorities, right, like Coastal Plains, we start to actually service youth at age 3. We have seen just through statistics that even infants start to display signs of anxiety. And there's different reasons, right? Think of a youth who, while in utero, right, while developing in mommy's tummy, is undergoing a lot of distress, whether it's finances, whether it's relationship, whether it's housing, whatever stress she's experiencing, that is affecting baby. Okay, and so you now have baby who, once they enter this world, already has different things working against them, right? Their mind is already exposed to that trauma. And there's a lot of science behind it as well, right? There's a lot of science when it comes to serotonin, dopamine, cortisol, endorphins, right? So when you look at a young individual, a young child, pre-K, elementary, very early, those are very critical developmental ages, right? Those are the ages where their brain is like a sponge. And they're going to pick up those core developmental life skills. During that time, they should be reaching the milestones of learning how to love, learning what it's like to be held and nurtured and cared for. They're also finding their own independence. But when they're experiencing extreme trauma, when they are being pulled away from their home setting, the only home that they've known, the only parents that they've known, that in itself is trauma. Even though it's not anything, this could have been a youth who was never physically abused, never sexually abused, but it was due to substance use on the parent's part or the guardian's part. And so child was removed. That's trauma. And so instead of allowing them, right, instead of their mind focusing on reaching those milestones and developing at the rate it should, right, as a normal child would, their mind is set and stuck where that trauma is. So they're aging because that's what's going to happen. The timeline is going to continue and we're going to continue to age, but their mind is stuck at age 3, at age 5. And so it takes them longer to start to go back and reach those milestones. It takes them longer to actually process what's happening around them. Because in their mind, what they're thinking is, I want to go home. I want to, it's like survival mode. Okay. And so they're just constantly focused on that. Do they know that? No. Do they actively know that that's happening to them? No. And this is where I say the behaviors, the challenges start to present and we see them as behaviors. So you think of the youth that the school is always calling, guardian or foster parent and saying, this kid, we can't do this, we can't do that. They're always disrupting the class. They're having tantrums. They're throwing themselves on the floor. They're throwing this, they're destroying that. Okay, but what are we doing? What are we doing to identify that this is a mental health challenge and not just behaviors? What's causing this? What's triggering this? What's happened? Because a lot of the time, again, that's a form of anxiety that's being displayed. The reaction that an adult usually has with that child, if not appropriately trained with mental health to understand what it is, it's to be more aggressive, right? It's the power struggle. It's to come back and to raise the voice and say, I told you, you have to do this, this, and this. And that gets nowhere. That leads to nowhere. So for the youth that you're, one of the youth that you're working with, Marian, I would say going back and looking to see, the age range that when this child was first removed from placement, what was the situation? And then backtracking. What milestones can they, have they actually achieved? Where are they at? What other skills can we, put in place with the school that they're attending so that we can help them learn the additional, life skills that they need in order to reach the milestones? It's very possible. Again, recovery is very possible in any stage, and recovery is different for everybody. For this youth, recovery looks like, or could look like, reaching those life milestones so he is very close to his age range. He may not, catch up completely, but trying to get him as close as possible so that he's able to, meet his peers where they are as well. Developmentally, emotionally, he's able to catch up. But you have to address the mental health component in order to then allow him, his brain, the capacity to process everything else around him, everything else in life. You're muted.
Yes, I muted. Yeah, sorry. You saw my mouth moving? Thank you. Thank you. I'm glad you started 3, and Nicole, I'm happy to hear that. And there was a bunch of kids, and let me just mention this other kid in that bunch of kids. They were removed and they went to a relative, that he knew, a grandparent. And he didn't speak for the first 2 weeks, right, that he got there. And his speech was behind, and now that one is getting speech therapy. But somebody he had known before, when they got removed and he went there, like at 3 years old, he didn't speak for 2 weeks. And then now he has a speak because he started, and they weren't going to school before. So when he started school, they couldn't understand him. He wasn't speaking properly. Now, and every single one is a fighter, one is a cusser. They're all different things. But now I see the mental health part of it. And unfortunately, and I'm not slandering anybody, sometimes when they get evaluations, they get blanket evaluation, and every child gets the same story, trauma from removal and blah, blah, blah. They don't really get to it. So they're never going to get the mental health services. So I'm glad to hear about you and that you're connected with Nicole and that you know about services and stuff. And I'm hopeful that one day we will not just look at behaviors, we'll also look at the mental health trauma. And there's one trauma that you left out. You spoke about it tangentially, that they remove because the parents use drugs. But there's another trauma that they go through in uterus when the parents is using drugs and the child is born with drugs in their system. That's
Yes,
disaster. That's
yes.
recipe for disaster and mental health problems.
Yes, it does. It does. You know, it's just like talking about, well, you know, when the parent underwent significant stress. There's so many, again, risk factors that are already that infant is being faced with just from the get-go, you know? You think here's this young, innocent, vulnerable baby, and they've already got so many different mental health challenges and medical challenges that they will be faced with. And so, you know, are they able to work through that? Yes. There's, you know, different systems in place to help with the addictive, right? The addictiveness that they're born with. I can say that I'm on a mission. I'm definitely on a mission with this program. And, you know, it's something I'm very passionate about. Like I said, I've been in that scope as well. And so I know it's greatly needed. And my goal is to continue pushing through mental health, working with organizations like GASA, working with DFPS, because it has to be those frontline workers who are not just processing paperwork, who are not just seeing this as another case, who are not labeling all the cases the same, but can see each individual need for what it is and working to actually address the mental health challenges, the behavioral health challenges that we're being presented with.
Awesome. Thank you so very much for joining us, Abigail. If there are no other questions, I will go ahead and wrap it up at this time. But I'm really looking forward to having you come back and share with us more information. And we're really excited about the work that you're doing.
You know, I appreciate you all giving me the time to really just provide you with information, and I look forward as well. If there is any specific information that you'd like to know about, just shoot me an email, you know, and I'll do my best to pull it together for you.
Awesome. Thank you again, and we'll talk soon. So have a good day, everybody.
Thank you.
Thank you.